ultrasound, a guide for early detection of congenital anomalies. I think this is going to be a new topic, probably, or maybe I haven't done this thing. Let's start, ma'am. Thank you very much for coming on the platform.
Yeah, good evening, everyone. And my sincere thanks to Radiologist Forum of UP for this opportunity, and just hope that you all are in good health. So we understand that in the past decade, there has been a shift of paradigm towards early diagnosis of congenital anomalies. And let's see how coloring the fetal abdomen helps us achieve this. Can you hear me, Tanuj?
I can hear you, ma'am.
Yeah, can you hear me?
I can hear you. It's okay. You continue, please.
Okay. So my disclosure is about some images which I have picked from literature and some which I have borrowed from my colleagues and seniors, which I have duly acknowledged in the presentation. As a common practice, we do color the fetal abdomen for ductus venosus, renal arteries, and to rule out single umbilical artery. But there is more to abdominal vasculature than this. The altered course of blood vessels in fetal abdomen that is seen in some rare congenital anomalies reveals some recognizable patterns and clues that render these anomalies more detectable, and that's the rationale of the talk. So, Tanuj, can you see my entire screen, or is there some box out there? Hello?
Box was visible earlier. Right now, this size, yes, there's a box which is saying, please move the window away from the area.
This box is there now. This box should be
from the shared application.
So we'll go by looking at how the normal fetal abdomen looks like on color Doppler in sagittal transverse and coronal views. And then we'll come to difficult to detect anomalies, which are rendered more detectable by color Doppler in first trimester. These are a group of similar ventral masses, and we have bladder, exstrophy, and umbilical cord cyst. Where diagnosis and differentiation are difficult to discern. So these will be similar ventral masses, which we will differentiate by putting color in the abdomen. Other cases, diaphragmatic hernia, renal agenesis, single umbilical artery, and Ductus venosus. All of these will color the abdomen and see how it helps. Second trimester, we'll look at normal anatomy of umbilical portal-ductal venous system in sagittal and transverse views, and the related anomalies like PRUV, and I'll click on portosystemic shunts as well. So this is how a normal fetal abdomen looks like in sagittal view when we put color in the abdomen. This is a triangle formed by aorta, umbilical arteries, one behind the other, and umbilical vein, like that. This triangle is seen as early as 10 weeks, and in a little tilted plane, we'll see the two umbilical arteries separately. And this is also to emphasize that umbilical arteries have an initial oblique course as it anchors the urinary bladder there. Umbilical arteries, we know, are landmark to urinary bladder, and they anchor or skirt the bladder in the place. So this oblique course of umbilical arteries make an acute angle with aorta. This spatial relationship is an acute angle, K angle. And we'll see how it is important. This K angle is seen from 10 weeks onwards. And then the umbilical artery is seen to be intersecting with umbilical vein and the abdominal wall at umbilicus. This ensures that umbilical artery is emerging at the umbilicus. This intersection is seen from 12 weeks onwards. So these are the cases of the bladder, the triangle and acute K angle at 10, 11, 12 weeks. And you can see that intersection out there and
खाने में अच्छा है, थोड़ा मीठा कम है.
all the
Just एक minute, ma'am. I guess Dr. Anil Kanaya sir, Dr. Balian sir, please switch off your mic, sir.
Anuj, am I audible?
Mute all.
Yes, you are audible. You continue.
Should I continue?
You continue. Remember that there was two mics were on were not on unmute mode.
All right.
Now you continue now.
Also on sagittal view, we see the superior mesenteric artery pointing downwards towards the direction of small bowel. And that's the celiac axis up there. And SMA is seen from 11 to 12 weeks onwards. So this is what I've been talking about, the triangle, which is seen on coloring the fetal abdomen. That's the acute K angle there and superior mesenteric artery pointing downwards. This is the intersection of umbilical artery and umbilical vein. And this is to say that femoral artery, which is going towards the lower abdomen, limb, should not be mistaken for umbilical artery. So we need to look at umbilical artery aorta angle and not the femoral artery aorta angle. In transverse view, we also see the ductus venosus arising from umbilical vein. This is anechoic channel with echogenic outlines, and on color this shows arising because of high velocity in the ductus venosus, because this blood has to flow to right atrium and then subsequently to the left atrium through foramen vein. And this is the detail of anatomy of ductus venosus, the course of ductus venosus as it arises from umbilical vein at an angle and then joins the subdiaphragmatic venous vestibule, which is also joined by the inferior vena cava and the hepatic veins. This is the left hepatic vein there. And ductus venosus, this trumpet-shaped structure drains into the subdiaphragmatic venous vestibule. And this is a high velocity so that the oxygenated blood, which comes from the umbilical vein, does not mix with deoxygenated blood from hepatic veins and IVC. And this is to show how ductus venosus arises from the umbilical vein and is joined by the hepatic veins as it joins the IVC. And in sagittal view, that's the ductus venosus, the arising there, which emerges from umbilical vein and joins the subdiaphragmatic venous vestibule, which is also joined by the inferior vena cava and the hepatic vein there. The spectral Doppler of ductus venosus, we all are familiar. That's the positive A wave in a normal fetus. The reversal of A wave is important. This is contamination of ductus venosus with umbilical vein if we interrogate the vessel too close to the umbilical vein, and this is contamination with hepatic vein if we do it too close to the hepatic vein. But if you see the A wave is still positive, so this is a false reversal because of contamination with hepatic vein. And why is the spectral Doppler so important? Because reversal of flow in ductus is observed in only 3.7% of euploid fetuses, but in 70 to 76% of fetuses with trisomies. But now we also look at ductus venosus PI, which should be more than 95 centile to consider it as a marker for aneuploidies and congenital heart disease. And in transverse view of, in the coronal view of the abdomen, we look at the renal arteries. This is in first trimester and this is in the second trimester at anomaly scan. And a single absence of renal artery on one side suggests renal agenesis on that side. Also, if we see sagging renal arteries pointing caudally, uh, so that the angle between the renal artery and aorta is less than 55 degrees, this is suggestive of horseshoe kidneys. And horseshoe kidneys we know is not very uncommon, and it is associated with aneuploidy and other malformations. This is interesting to look at that. In transverse view of lower abdomen, we see the two umbilical arteries converging across the bladder. And this is important not only to ascertain that we have two umbilical arteries there, but also to ascertain that urinary bladder is contained in the pelvis and umbilical arteries are converging across the urinary bladder. That's the single umbilical artery there. And this sign is seen from 12 weeks onward. And this is a case by my teacher, Dr. Bimal Sahni, where this aberrant vessel in the abdomen is the single umbilical artery, which is arising from abdominal aorta at the level of superior mesenteric artery. So the two umbilical arteries on the side of urinary bladder was not seen in this case in transverse view. Instead, in sagittal view, this is what was visible. And this single umbilical artery, which arises from abdominal aorta, is type 2 single umbilical artery. This is a rare condition which is seen in almost 1.5% cases of single umbilical artery. So now that we know how a normal abdomen looks like on color in sagittal, transverse, and coronal views, let's see how we apply this information to differentiate similar ventral masses. So I'll be taking exstrophy bladder, omphalocele, and umbilical cord cyst. Exstrophy bladder we know is a rare anomaly, and the dilemma in diagnosis arises because it can present as a cystic mass or a soft tissue mass or no mass at all. Protrusion of posterior bladder wall through deficient anterior abdominal wall and deficient anterior bladder wall is what actually happens. Non-visualization of urinary bladder in the presence of normal kidneys and normal AFI suggests the diagnosis. Omphalocele is comparatively common, associated with chromosomal anomalies in 40 to 60% of the cases where bowel forms content, so we need to look at this. And umbilical cord cyst is more common, 3% of the pregnancies. Omphalomysenteric cysts are typically located near the fetal cord insertion, so they could mimic cystic variety of bladder exstrophy. Also, umbilical cord cyst could be associated with omphalocele and underlying abdominal wall defect, hence the need to differentiate the three close mimics. So let's come to the cases now. This patient came to me at 17 weeks, and this was the first ultrasound. I could see the cystic ventral mass from the fetal abdomen, and when I colored the abdomen, I could see the aberrant course of umbilical artery. So instead of the oblique course of umbilical artery towards the umbilicus, which happens in a normal fetus as so, here the umbilical artery was more upright, stretched and straightened as it emerged along the cystic bladder exstrophy mass, and this resulted in widening of K angle. So instead of normal acute K angle, here the K angle became rectangle. It was 90 degrees here. And also there was distorted triangle, which I had spoken about. This triangle was incomplete and distorted. And in transverse view, the umbilical arteries fall apart because of intervening cystic bladder exstrophy mass. This is normal appearance, and this was the case of bladder exstrophy. And this was 16 weeker, and the patient got it aborted, and the abortus showed bladder exstrophy as a cystic ventral mass and omphalocele there. Sorry about this. Okay, so this was a cystic bladder exstrophy and omphalocele there, and meningocele imperforatenus. This was ambiguous genitalia, low insertion of umbilical cord and clubfoot. So this was a case of OEIS complex. Another case with cystic type of bladder exstrophy. This was isolated bladder exstrophy. On coloring the abdomen, the altered course of umbilical artery was staring at me. And this umbilical artery was emerging much below the umbilicus. Instead of oblique course towards umbilicus, it was emerging much below, along the side of cystic ventral mass. And so the K angle was widened. This image of the same fetus, look at the K angle, it is obtuse here because umbilical artery is emerging here rather than going all the way towards the umbilicus. And on transverse view, we have umbilical arteries falling apart because of cystic bladder exstrophy mass there. Another case of OEI is complex at 11 weeks. And this was omphalocele and a cystic mass there. On coloring the abdomen, the course of umbilical artery was altered as it emerged alongside the cystic bladder mass. And so the K angle was widened. It was 125 degrees here. Instead of oblique course towards umbilicus, umbilical arteries was emerging much lower down, much below the umbilicus along the cystic ventral mass, leading to widening of K angle there. That was the clue to bladder exstrophy. Prone position, widening of K angle, again widening of K angle here, and you see the completely distorted triangle, which I had spoken about. Another case of bladder exstrophy at 16 weeks, courtesy Dr. Vipin Goyal. The umbilical arteries are upright and straight, emerging right here, much below the umbilicus, instead of oblique course towards the umbilicus. And this then traveled on the surface of abdomen to exit at the umbilicus. This patient did not have any ventral mass. There was just some irregularity on the surface of lower abdomen and the bladder was not visualized. And this patient also, this fetus also had caudal regression syndrome. So wide K angle and altered course of umbilical artery and distorted triangle were clues to bladder exstrophy. This was a 16-weeker as well. Another case of exstrophy bladder. This is courtesy my friend Dr. Gina, and this fetus was just 11 weeks. There was omphalocele, there was cystic bladder exstrophy, and there was meningocele there. And these are the 3D images of meningocele, omphalocele, and on coloring the abdomen, we see the umbilical artery emerging right here instead of oblique course towards umbilicus. It is emerging much lower down along this cystic mass, which was a bladder exstrophy. And the K angle was widened. This was an obtuse angle here. So this is a picture from internet to show that bladder exstrophy can present as no mass at all. And to diagnose this article speaks of a low insertion of umbilical cord, that is distance between a lower end of umbilical cord and genital tubercle. They have come up with nomograms and they say that less than 5% of that particular value for that particular gestational age is low insertion, but they have studied cases from 15 weeks to 17 weeks. So 15 to 17 weeks low insertion of umbilical cord can be a clue to bladder exstrophy, but there's no literature which talks of early diagnosis of bladder exstrophy in first trimester. So talking of K angle as a clue to the diagnosis of bladder exstrophy in first trimester is something which takes no mention in literature. And these are pictures from literature to show how bladder exstrophy looks like when it presents as a soft tissue ventral mass. These are the umbilical arteries emerging along the side of bladder exstrophy. That's the posterior wall of bladder bulging there. And the umbilical arteries are seen to travel alongside this bladder exstrophy mass to emerge at the umbilicus. And when we color the abdomen, we see the umbilical artery, instead of traveling towards the umbilicus, it's emerging right here along the bladder exstrophy mass, and this results in widening of K angle that I've spoken about. So how is it that sometimes bladder exstrophy presents as soft tissue ventral mass? At other times, it presents as cystic ventral mass. We need to understand embryology, and this is very important. So in brief, we see this. The cloacal membrane is seen to be covering the primitive cloaca. This is endoderm and ectoderm of the cloacal membrane. Normally, by 7th week, the cloacal membrane transcends down there and the anterior abdominal wall is complete. That's the urogenital septum, which divides the cloaca into bladder and anal canal. Subsequently, the cloacal membrane ruptures here to establish the openings. But in bladder exstrophy, the cloacal membrane persists here in the infraumbilical region and ruptures while it is still here. So a defect is established in the infraumbilical portion of the anterior abdominal wall, and this defect is the bladder exstrophy through which the posterior bladder wall emerges, because anterior bladder wall and anterior abdominal wall are formed from this cloacal membrane, which actually ruptures, and so the two membranes are absent and the posterior bladder wall emerges as a soft tissue ventral mass. And in case of cystic bladder exstrophy, the cloacal membrane is intact and it emerges as a cyst. And this cyst is remains intact till 22 to 24 weeks, after which it ruptures and the posterior bladder wall emerges. So this is how we explain the cystic variety of bladder exstrophy. And this is a case at 16 weeks and 20 weeks. The same case at 16 weeks presents as cystic bladder exstrophy mass with umbilical arteries draping the cystic mass. And at 20 weeks, the cyst, the cloacal membrane cyst ruptures and the posterior bladder wall emerges as a soft tissue ventral mass with umbilical arteries on the sides of it. Coming to omphalocele, this case came to me at 12 weeks with a soft tissue ventral mass. So when I colored the abdomen, I saw the umbilical arteries, the intrafetal umbilical arteries have a normal course because bladder is in place and so are the umbilical arteries. And so the K angle is normal, but the umbilical vein is seen to be passing through center of omphalocele mass, resulting in a distorted triangle. Umbilical vein passing through center of omphalocele towards the prolapsed liver, and we see the superior mesenteric artery pointing upwards towards prolapsed small bowel. So umbilical artery has a normal course, normal K angle, but distorted triangle. And small bowel in omphalocele warrants karyotyping because these are the cases which actually are associated with aneuploidies. So by coloring the abdomen, we know the contents of omphalocele. Another case of ventral mass. This was a cystic mass abutting the abdomen, resembling cystic variety of bladder exstrophy, but bladder was in place, so were the umbilical arteries. And the cystic mass has umbilical arteries draping all around. So this could mimic cystic variety of bladder exstrophy, because bladder actually may not be visible at 11 weeks. In 50% of the cases at 11 weeks, you do not see the bladder. 10% of the cases at 12 weeks, you do not see the bladder because of low urine production in early pregnancy. And also there could be physiological absence and pathological absence. So it's important to color the abdomen and look at the K angle. So in cystic variety of, in umbilical cord cyst, the K angle is expected to be normal, and so it was. And the umbilical vein was intersecting normally with the umbilical artery. Thereby, the abdominal vasculature and the triangle were maintained. So the abdominal wall was intact. So we confirm that this was an extrinsic mass with no underlying abdominal wall defect. So comparing the three conditions, schematic diagrams, normally we see this triangle, this intersection there, normal K angle and umbilical arteries converging across the bladder. Exstrophy bladder, altered course of umbilical artery. This K angle is widened. This triangle is disturbed, and those are the umbilical arteries which fall apart. Omphalocele, normal course of umbilical artery because bladder is in place, K angle is normal, distorted triangle, but umbilical arteries have a normal course on transverse view because bladder is in place. Umbilical cord cyst, the abdominal vasculature is normal in sagittal view and transverse view because there is no anterior abdominal wall defect and it is an extrinsic mass. A case of diaphragmatic hernia. This is common on the left side, and small bowel is frequent constituent. Those are the images of superior mesenteric artery pointing downwards at 11 weeks, 12 weeks, prone position. And in diaphragmatic hernia, left-sided diaphragmatic hernia, the stomach was not seen in abdomen, it was seen in the thorax, shifting the heart to the other side, and upturned SMA suggested there was something else in the thorax, and that was small bowel there. Another case of stomach normally seen in the abdomen, but there was a mass in the thorax shifting the heart to the other side, and upturned SMA suggested that the mass was small intestine, and this was indeed a case of diaphragmatic hernia. So we know now that the upturned SMA suggests small bowel prolapse in a case of omphalocele and in a case of diaphragmatic hernia. So So to conclude this part, coloring the fetal abdomen in the first trimester, ventral masses with abdominal wall defect have an altered abdominal vasculature. Those with the no underlying abdominal wall defect have normal abdominal vasculature. Look for upturned SMA in CDH and omphalocele to suggest small bowel as contents. Single renal artery, single umbilical artery, and ductus venosus, we all are familiar. Coming to second trimester, we should look at the fetal venous system as well. Umbilical portal venous system is important, as also the systemic venous system. So those are the planes of the venous system. The plane 1 or plane A corresponds to hepatic veins. Plane B corresponds to portosystemic venous system. Plane C corresponds to systemic veins, the renal veins, and plane D corresponds to IVC. Now, coming to umbilical portal venous system, I'll be doing the anatomy of umbilical portal venous system and then the anomalies. So amongst the anomalies, I'll be covering the most common anomaly of umbilical portal venous system, that is persistent right umbilical vein, and then the umbilical porto-ductal systemic shunts, which I will touch upon very briefly. So this umbilical porto-ductal venous system, which has three main components, umbilical vein, portal vein, and ductus venosus, these three components can establish a shunt with systemic veins, hepatic vein or renal veins or IVC. And these are the shunts which are actually called umbilical porto-ductal systemic shunts. The anatomy of umbilical porto-ductal venous system. So the venous system, venous perfusion of fetal liver is unique. It is supplied by two venous systems, the umbilical venous system and the portal venous system or the vitelline system, which comes from gut. And the placental blood flow is shunted to the heart via this hepatic network. So this hepatic network is so important because it carries oxygenated blood from umbilical vein, from the placenta, which joins the left portal vein and turns to the right to form the portal sinus. The main portal vein carries deoxygenated blood from intestines, splenic vein, and supramesenteric vein, joins the portal sinus to form the right portal vein, the anterior and the posterior branches. So this is the left portal vein, this is the right portal vein, the main portal vein, and the umbilical vein. And we understand it better in the orientation of ultrasound. So if we consider this as a transverse view of abdomen, where we take the abdominal circumference. This is the schematic diagram. Umbilical vein carrying oxygenated blood from placenta, joining the left portal vein, which turns to the right to form the L-shaped portal sinus. Main portal vein carrying deoxygenated blood joins the portal vein to form joins the portal sinus to form right portal vein, the anterior and the posterior branches. Ductus venosus emerges from the angle of this L-shaped portal sinus. This is the corresponding image on ultrasound. That's the umbilical vein joining the left portal vein. These are the branches of left portal vein, the inferior branch, superior branch, and medial branch. Left portal vein turns abruptly to the right to form L-shaped portal sinus. And in a tilted plane, we see the main portal vein joining the portal sinus to form right portal vein, the anterior and the posterior branches. So this X-shaped configuration is really important because this is what confirms that umbilical portal-ductal venous system is intact. And the ductus venosus is seen to be arising from the angle of this L-shaped portal sinus. Now, so if we take a section through this, this is what we get. Umbilical vein and the left portal vein. The main portal vein is left behind, so we do not see it here. If we take a section through main portal vein, we see the main portal vein there and the X-shaped configuration there, but we do not see the umbilical vein which is left behind, so umbilical vein is not visible here. The spectral Doppler of portal vein shows respiratory variations. So the method of evaluation of umbilical portal venous system is coloring the abdomen in the section which we take for abdominal circumference. So it's easy, abdominal circumference section, just put color. In longitudinal section, we identify the normal course of umbilical vein and ductus venosus, which I have already spoken about, the ductus venosus arising at an angle from umbilical vein and joining the subdiaphragmatic venous vestibule. So on transverse view of abdomen, the view for abdominal circumference, we see the umbilical vein there, which turns away from the stomach as it becomes the portal sinus. Gallbladder and stomach are seen to lie on either side of umbilical vein in a normal fetus. And that's the X of the portal vein, the left portal vein, the right portal vein, and the main portal vein. Am I audible, Dr. Tanuj? Hello?
Yes, ma'am, you are audible.
Okay, yeah.
Yes, you are audible. Continue, please.
So, persistent right umbilical vein. So this is a 20-weeker. So PRUV can be diagnosed right from 20 weeks onwards. So we know in a normal fetus, we have left portal vein joining the left umbilical vein joining the left portal vein. But what happens in persistent right umbilical vein is that the left umbilical vein gets obliterated and the right umbilical vein persists, which joins the right portal vein to turn down towards the stomach. So this is what we see. Instead of straight course of umbilical vein, we see the right umbilical vein turning towards the stomach. And in this process, the gallbladder comes to lie on the same side as stomach. So normal case, we have left portal vein, which joins the left umbilical vein in a normal fetus, joins the left portal vein, turns away from stomach, gallbladder and stomach are on either side. In PRUV, the left umbilical vein obliterates, right umbilical vein persists, which joins the right portal vein, turns towards the stomach, and gallbladder and stomach lie on the same side. In sagittal view, we see the gallbladder just medial to umbilical vein. Normally, you do not see gallbladder in this position, and this sign raises the suspicion of PRUV. Cases of PRUV. In fact, out of my series of 8 cases of PRUV, I have picked 2 where we have associated anomalies. Here, there was absence of left kidney, and here it was single umbilical artery. This is to show that PRUV can present as 2 parallel anechoic channels close to the insertion of umbilical cord. And when we color the abdomen, we see one of the channel is filling with color. This is the umbilical vein, which is pointing towards the stomach. Remember, normally it is away from the stomach. And the other channel was gallbladder. Ductus venosus was present, and in sagittal view, gallbladder was seen just medial to umbilical vein in all the cases. So out of my 8 cases of PRUV, which I diagnosed between 20 to 35 weeks, 2 cases had associated anomalies. This makes 25%, and all the fetuses were born healthy. So normally we have right umbilical vein disappearing by 7th week and the left umbilical vein is left. But in PRUV, the right umbilical vein persists and remains open. This is the most common fetal venous anomalies, incidence being approximately 0.1%. It has a potential of association with other malformations where it is called non-isolated PRUV, which is seen in 25% of the cases, as also in my series. And these cases which have associated malformations, which are called non-isolated PRUV, should undergo karyotyping. The isolated PRUV, where there's no associated malformations, do not require karyotyping. Out of these 25% of the cases, 8% show aneuploidy, and hence the need for karyotyping. So we have 2 variants of PRUV. Intrahepatic variant, which is the common one, has a better prognosis, and ductus venosus is normal. All my 8 cases were intrahepatic PRUV. Extrahepatic PRUV is rare, almost 5%. Has a worse prognosis because ductus venosus is absent and umbilical vein drains directly into IVC or the right atrium, causing cardiac preload, CCF, fetal hydrops, and fetal demise. All these cases of extrahepatic variant are associated with additional abnormalities, and these are the ones which require karyotyping in all cases. Pathophysiology of PRUV is elusive. It could be folic acid deficiency or teratogens like retinoic acid. Associated anomalies are mostly cardiac in 60% of the cases, followed by renal, cerebral, GI, and limb malformations. And this is about 2 large multicentric studies. The results were comparable in both the studies regarding incidence of PRUV, extrahepatic, intrahepatic types. The only difference was this study claims cardiac anomalies as the common association. This one says it's renal. So the prognosis of PRUV, the intrahepatic type where ductus venosus is present, only 25% have associated anomalies, and these are the ones which require karyotyping. Prognosis is good depending on what the associated anomalies are. Extrahepatic PRUV, where ductus venosus is absent, 100% have associated anomalies. The prognosis is really bad with the association with CCF is there, and karyotyping is required in all. So points to remember. Assessment of fetal umbilical portal venous system is an important part of antenatal fetal surveillance and must be done in all level 2 scans. PRUV is the most common anomaly of UPVS. Look for it. Color Doppler for ductus venosus is necessary to ascertain the type of PRUV. Intrahepatic PRUV may be associated with structural anomalies in 25% and sometimes with chromosomal anomalies as well. That is 8% of this 25%. Extrahepatic PRUV are always associated with anomalies. PRUV prompts detailed anatomic evaluation and fetal echocardiography. Karyotyping is individualized depending on the type of PRUV and associated malformations. Isolated intrahepatic PRUV carries a good prognosis, does not require any invasive testing. Prognosis in non-isolated PRUV depends on associated anomalies, and extrahepatic PRUV has a bad prognosis. So PRUV is worth a notice and worth a mention in every level 2 scan. Briefly touching upon umbilical portal-ductal venous system. So when to suspect umbilical portal-ductal venous shunt? When we have absent ductus venosus in first or the second trimester, when we see absent intrahepatic portal venous system. So the X there, the X of intrahepatic portal venous system that we see in the right side of abdomen is not present or it is incomplete, raises the suspicion of shunt. If we have IUGR for no reason, any abnormal vasculature, any abnormal aberrant vessel in the abdomen or any abnormal jumble of vessels in the abdomen raises suspicion of shunt. And these are the 4 planes we have seen already. So plane of hepatic veins, systemic veins, the plane of portal venous system, the plane of renal veins, and plane of IVC. So these shunts, portal venous systemic shunts, arises when we have shunting between any part of umbilical portal venous system, the umbilical vein or the portal vein or the ductus venosus, communicating with hepatic vein or renal vein or IVC. So it could be umbilical vein systemic shunt, portal vein systemic shunt, or ductus venosus systemic shunt. I'll be touching upon umbilical vein systemic and ductus venosus systemic shunt, which can be diagnosed in first trimester and second trimester anomaly scans. And why are these shunts important? Because they could be associated with aneuploidies. This is an article by Dr. Ravi Choi, which says a new vascular sign. Vascular anomalies of umbilical portal ductal system could be the most common vascular defect in Down syndrome. And he reports 2 fetuses of Down syndrome with absence of ductus and umbilicosystemic shunt. Another article which mentions association of shunts and absence of part of umbilical portal ductal system or the ductus venosus is this article, which reports 2 patients of trisomy 21 with these shunts. Another article which shows umbilical vein draining into IVC, that's umbilical vein systemic shunt in a case of Turner mosaicism at 20 weeks. And this was a case of trisomy 13 at 12 weeks, 5 days, showing umbilical vein ductus venosus communicating with IVC. And this is to say that these shunts are an association with trisomy 18, 13, monosomy X, Noonan syndrome, besides trisomy 21. So umbilical vein can be communicating with IVC with or without ductus venosus. So this is a case courtesy Dr. Bijoy, and umbilical vein is seen to be seamlessly going into IVC. This is umbilical vein systemic shunt. Another case of ductus venosus systemic shunt. You see the aliasing there. Ductus venosus systemic shunt has a much better prognosis than umbilical vein systemic shunt because you have aliasing there, you have a narrow segment there which causes resistance in the portal venous system because of back pressure. And so the intrahepatic portal venous system is intact. There are collaterals in the liver and the liver is well perfused. So ductus venosus systemic shunt have a much better prognosis. Umbilical vein systemic shunt have very bad prognosis. Both can be associated with chromosomal abnormalities, but survival is really bad in umbilical vein systemic shunt. So to summarize, umbilical portal-ductal venous complex is an integral vascular unit, and each component of this can produce a shunt with fetal systemic system. And these are called umbilical portal-ductal systemic venous shunts. Integrity of the intrahepatic venous system is a key to live birth in any type of shunt. So if you have an intact X there, if you have an intact intrahepatic portal venous system there, any kind of shunt has a good prognosis. Survival is really good. So you just have to make sure that intrahepatic portal venous system is present and ductus venosus is present or not, that is to be seen, and you are fairly done. Karyotyping is required in evaluation of all cases of shunt because all of them could have association with aneuploidies. To wrap up, we color the abdomen in the first trimester to eyeball for this triangle, eyeball for the acute K angle, look at the superior mesenteric artery pointing downwards, look at the renal arteries, any sagging of the renal arteries to rule out horseshoe kidneys. Look at the umbilical arteries converging normally across the bladder, which ensure that the bladder is in place. Look at the presence of ductus, the course of ductus, and interrogate ductus for spectral Doppler to look for reversal of A wave and the PI in the ductus venosus. In second trimester, besides what all we can see in the first trimester, we also look at the umbilical vein turning away from stomach and this X there, which says that intrahepatic venous system is intact. So even if we miss a shunt here and there, we are much sorted if we see the X is there. Now, this is the gist of my talk. This is to say that K angle is widened in bladder exstrophy, and this is a important tool to diagnose bladder exstrophy in first trimester. This was a case of 16 weeks. So all the 5 cases I'm summarizing. Case 1, 16 weeker with wide K angle. Case 2 is again a 16 weeker with wide obtuse K angle. This was an 11 weeker, which shows a wide K angle, which was a clue to the diagnosis of bladder exstrophy. A 17 weeker with a wide K angle, that's a rectangle, that's at 90 degrees. And case number 5 is also a 11 weeker with obtuse K angle there. This is my article in IJRI. Published in December 2017. This is about newer approach to diagnosis of bladder exstrophy by color Doppler. Now, why we cannot afford to miss bladder exstrophy? You know, bladder exstrophy is a debilitating malformation which has a paramount impact on quality of life. So it's important to diagnose bladder exstrophy, and literature reports only 15% cases of prenatal diagnosis of bladder exstrophy. And till date, in current literature, there is no objective parameter that suggests the diagnosis of bladder exstrophy in first trimester. So I have endeavored to diagnose bladder exstrophy at 11 weeks in the first trimester by looking at K angle, which has a huge potential to diagnose bladder exstrophy. So widening of K angle is important. Look at it in every level 1 and level 2 scan. Thank you very much. Dr. Tanuj? Hello?
I was disconnected, just joined again.
You were
I was disconnected for last 2 minutes.
Okay, but was I audible all through?
Yes, you are audible all through.
Okay, all right.
Right. Uh, uh,
Hmm.
you wanna continue? Is this end of presentation?
Yeah, this is the end of the presentation. Yes.
Right, right. Because I disconnected, that's why I'm not able to see that. Thank you, Dr. Kavita. To me, this lesion, this presentation is of very high level, and to be very frank, still, it's really difficult to see all the structure you have shown to the members.
Uh-huh.
Uh, for me, this is definitely different, a difficult subject or a difficult presentation for me. I don't know whether I will be be able to diagnose all these things or not, but need to learn a lot to understand the topics and the contents.
Okay, so
Uh,
I don't mind answering any queries, any questions.
let,
And
let
I
me.
just want to say that it is not difficult. It's just that the eyes
Practice.
don't see what the mind doesn't know.
Yes.
So once
That
you
is,
start looking at the abdomen from this perspective, once you start coloring the abdomen in every single scan at level 1 and level 2 scan, you will see how easily you see the triangle
yes,
there,
yes, yes.
see the
But
K
this is a
angle.
good guide for, this is a good guide, but still, at present, and the present situation of mine is difficult for me.
Okay.
Maybe the many people are used to of such things, because I have seen a cases of persistent right umbilical artery by a member of this group. At that time, I thought, okay, I will diagnose it someday, but it looks very difficult now, seeing the anatomy and the K sign and the X configuration. Maybe the other people are, maybe the younger lot is quite used to with all these things. Let's, can we ask question on the WhatsApp?
As you say,
It will be better. It will be better
okay.
to answer the questions.
All right.
Let's move to the WhatsApp
Oh,
right
okay.
now.
So I disconnect.
Oh yeah, oh yeah. Okay,
Okay.
right.
Thank you so much. Thank you.
Oh, okay, ma'am.
Nice, informative, interesting talk. Thank you.